Thank you. Stefano Occhipinti. That's I don't want to stigmatise you for saying the name. But yeah, thank you, Nita, and thank you all for staying for this final session. And of course, we've got to talk after the final session too. So I'll try not to take up too much of your time, and I certainly will try not to be bogged down in slides with lots of words in them. You've been hearing about stigma, and actually stigma has been mentioned in every single talk that I've been able to see so far since lunch. So I won't belabor that part. We know that stigma is a property that accrues to a group, not people. The earliest discussions of stigma in social science, it's been discussed for thousands of years, but in social science, the earliest discussions of stigma often spoke about health, and health conditions were some of the key stigmatized marks that were discussed. We know that stigma has key psychological and physical outcomes in terms of health. In particular, for example, stigma often prevents people from seeking primary care and prevents people from seeking health care until often it's quite a bit later. In the field of cancer, which is where I've done a lot of my previous work, in stigmatized cancers, people are often diagnosed at later and more complex and difficult stages, for example. Now, there's been a lot of work done on mental health stigma, rightly, because it is a great big problem in that area. And indeed, in Hong Kong, there's also been quite a lot of really good work done in mental health stigma. There's been less work done generally, and still less work, I think, done in Asia, with Asian populations, on general health stigma, which is what I'm going to be talking to you about this afternoon, and in particular with respect to HIV and people living with HIV. Stigma, I'll just briefly note on the right-hand side, is Irving Goffman's original work from the early 1960s. He talks about signs that refer to the moral status of the bearer. Stigma is about morality, and often we forget that. That is, the stigma is a thing that people use to make judgments about morality, that involve morality. And it helps groups to try to stay away from the blemished person, to keep them away. These are themes that are going to come through the data that I'm going to show you. So we know that stigma accrues to the individual, and of course it often occurs in interpersonal contexts. However, of course, stigma is really about a group. You don't stigmatize a person, you stigmatize the group to which that person belongs. And that groups are set within a societal and a cultural context. We can't avoid that, although often we tend to try to apply one single model of stigma to all the different sorts. And this can be sometimes a little bit of a hindrance. One of the key explanations for stigma, though, and this follows on from the work of Irving Goffman in the 1960s, is by link and feeling. This is very widely cited and discussed. And the three key points of stigma, according to link and feeling, are first of all that we have to have groups that can be labelled, that in some way stand out, either visually or cognitively. Secondly, these are connected to chronic beliefs about these groups, and often these are negative, because we're talking about stigma. It's not a pleasant thing, and we've heard about the stigma which is experienced and felt by people living with HIV this afternoon and indeed throughout the day. Thirdly, the crucial ingredient is about social power. Stigma is not about anything positive. Stigmatized groups in some way start to lack social power, and the mainstream is able to kind of use the greater social power that they command, and we can see this economically, we can see this quantitatively as well as qualitatively, is able to use the greater social power to limit the opportunities and to in various ways reject the advancement of the stigmatized group. And so the avoidance and the status loss that we see in stigma are essentially a function of these three key features, and we know that these are all cultural processes. I'm not going to spend very long on this at all. This is a blowing of the trumpet in some ways, given that we've sort of talked about all of these things. Some work that our group has done over the years, more recently. And I guess to provide some context for the data that I'm just about to show you, some colleagues and I did a large-scale study with US adults, and we sort of found that, in fact, there were some three key separate functions of stigma, that all stigmas were not the same, and that some stigmas were about shielding us from immoral others, sort of guarding our morality. Some stigmas were about keeping us away from people who interpersonally, or groups who would interpersonally bring us down, who would lower our social status. And there was a third sort of more chronic type of stigmatization that I won't talk about here. But in particular, these different functions of stigma were associated with different emotional responses to those stigmatized groups, and that is going to be of relevance to the data that I'm going to talk about. The other thing that I just would bring up is a study I did a few years ago now with lung cancer patients and caregivers in Australia. This was a qualitative study as opposed to the quantitative. And incidentally, lung cancer is another health condition where, in fact, people with lung cancer feel that they're seen, and that they feel like they are, and they feel that they're seen as less worthy than sufferers of other cancers. And they often compare themselves to, for example, to people with breast cancer as being less positive, and they also report stigmatization and negative responses from healthcare providers. So there are certainly parallels here. One of the things I found that in lung cancer stigma in particular, there was a very strong sense of moralization. It wasn't just about the personal responsibility of someone choosing to smoke and then winding up with lung cancer. And of course, we know that that's not the whole story, but this is the stigmatizing thought. But it was often about moral judgments. And indeed, that the stigmatizing interpretations were widely shared. And this is another thing that we should be thinking about. We're talking again about societally shared beliefs, not just beliefs amongst certain individuals, but widely shared. In fact, I talked to patients and carers who were smokers and non-smokers, because up to 30% of people with lung cancer, in fact, are not smokers. All sorts of reasons for that. They all understood the same stigmatizing beliefs that were promulgated. It's impossible to tell them apart on that basis. Stigma is a socially shared phenomenon. So this brings us to this notion of structural stigma. And so I guess the chief proponent of structural stigma in the last few years has been Mark Hatzenbuehler in the US. And there are two kind of aspects, or two major aspects to structural stigma. And at a policy level, he sort of notes policy as being the first level. And this is what many people, especially those trained in a more sociological tradition, would see as being structural stigma. It's about social structure. The structures of society are lined up to exclude or somehow hinder the progress of stigmatized groups. And so we know that this can happen in terms of access to treatment. We've heard about people's access to particular HIV treatments, for example. Recognition of relationships and all sorts of other things that occur in society that in some way are prevented or are denied to members of a stigmatized group. The other aspect of structural stigma, and again we'll be talking about this in the data, is this idea that it represents a sort of a synthesized general negativity of belief in society. I've called it there a summation of the negative beliefs about stigmatized groups. And so we've got some data on that too. So we're sort of looking then at structural stigma more broadly about people with HIV, as it happens in Hong Kong. Now, this is data from a much larger cross-cultural mixed methods study, and that's got about 1,500 people in it. I'm taking a small, about 220 portion of that, which are comparing respondents from Australia and respondents from Hong Kong, representative general public samples tested online with the aid of essentially a data gathering company. I won't go on about this sort of boring part, and I'm specifically comparing Australia and Hong Kong in terms of the respondents, and I'll show you why in just a second. We asked people questions about moralisation, the extent to which a particular health condition was seen as being linked to moral causes. We asked them about public stigma, especially in terms of emotions experienced in response to the target group. We asked them beliefs about social structure, and also about the sense of perceived prevalence and personal risk for the health conditions, because we know that sometimes conditions that are seen as being linked to more personal risk are potentially more stigmatised. And finally, we touched in on the idea of family blame, because families also bear the brunt of a lot of stigma, especially when it comes to health. We know that there's a big aspect of family stigma in mental health, and it was particularly relevant to a range of different health conditions. Now, we asked all of these questions of everyone. We asked them about different health conditions. I'm showing you the people who were specifically asked these questions about HIV. And we also asked them their perceptions of an imaginary person living with HIV. We asked them the questions that are generally used in social psychological research to gauge what we call person perception. So basically, I'm going to be showing you the data now. So just before this, I'm talking about the quantitative data, but prior to this, we did a qualitative component. And as it happens, we asked people about stigmatized conditions in a fairly indirect way to not prime them. But spontaneously, we had about 40% of respondents from HK nominated HIV/AIDS as being a stigmatizable condition, a condition that drew stigma within their society. In Australia, there was no, these are the top 8. There was sort of, if anything, negligible mention of HIV/AIDS. Australians certainly stigmatise things. There's no doubt about that. But by comparison, it's a much lower level of stigma associated with HIV/AIDS, not absent, but lower. So it provides a sort of a natural kind of comparison point. And also, a lot of the work in Australia is based on the kind of dominant Western conceptions of stigma, which I suggest may not be completely applicable to the East Asian and the Hong Kong setting in particular. In each of these bars, the blue bar is Hong Kong, and the kind of pinky bar is Australia. So we can see that indeed people in Hong Kong believe that most other people in Hong Kong see HIV as a condition that's linked with more moral causes than other conditions, and they believe this to a greater extent than Australians. So we've established that sense of moralisation. There's other data that comes to bear on that. Oh, I beg your pardon. Now we're going to talk about public stigma. So this is, to what extent do you think people in your culture feel the following emotions about members about people with the particular health condition, which in this case is, of course, HIV. So people in Hong Kong have a higher belief that the people would feel threatened, afraid, and less happy. Ooh, sorry for the shouting there. Interestingly, no difference in pity. So they don't believe that people in Hong Kong would have less pity, but they are higher in threat, afraid, and happiness. Not surprisingly, given the moral basis of stigma, and this is, by the way, HIV is not the only health condition that has a clearly moral aspect sort of to it in terms of the stigma. This is actually a very broad phenomenon. It's not in any way linked merely to HIV. Disgust is the emotion that's linked with morality. So people, they were higher in disgust, but not higher in anger. And anger is another emotion that's linked to morality. They were more frustrated and embarrassed, which kind of link in many ways. We asked then about social structure. Now, interestingly, when we asked them about the likelihood of gaining employment for a person living with HIV, about public education about HIV, about media reports about HIV, there was no difference between the Hong Kong and the Australian respondents. Their beliefs about these potential sort of difficulties here were not different. However, where they were different was in, and this is, by the way, this is difficulties in finding an intimate relationship. So in Hong Kong, people perceive these to be perceive there to be more difficulties than in Australia, and also in finding treatment for HIV. And we've heard about the ways in which we're trying to make treatment more accessible. In fact, this very afternoon, again, Hong Kong saw more difficulties with these aspects of social structure. Now, then we looked at, as I said, at the perceived epidemiology. Maybe people in Hong Kong are sort of showing this higher level of public stigma because they're more, they seem as they're more threatened. Maybe they think it's more likely that they'll come to deal with it. But in fact, no, there's no difference there at all in the perceived prevalence, nor is there a difference in personal risk. In fact, personal risk is quite low. So what we're seeing does not seem to be associated with some idea about how how widespread and about how personally risky HIV is in either Australia or Hong Kong. Interestingly, HIV is seen as being more controllable in Australia than in Hong Kong. The important thing about this is that very robust finding in most Western samples is that the more controllable a health condition is, the more it's actually stigmatized. The more that it's out of your control, the less it's stigmatized. And it's believed because it's about personal responsibility. If it's under your control, it's up to you to be able to not in some way get the condition. People talk about this in terms of lung cancer. You could have chosen not to smoke, therefore it's under your control. Interestingly here, and this fits with other parts of our data and other parts of other people's data, I think it's a fairly robust finding. There are lower perceptions of controllability in Hong Kong, not higher, and that's actually significant. Then we move on to then family blame. And so this is, again, we ask these of all the health conditions. To what extent is the family responsible? Members of the family of the person responsible for them getting this health condition? And this is quite interesting. There was clearly an effect here. So in terms of the family's bad luck, so again, the blue bar is Hong Kong. In terms of parenting, which is an interesting one from my point of view, genes, the effect is there. It's a bit smaller, and then also maternal pregnancy behaviour. But of course, in some ways, not surprisingly, given what we also know about the stigma that accrues to people living with HIV. Beliefs about sin and immorality were much higher in Hong Kong than Australia. The important thing about this is, of course, we're talking about the sin and immorality of the family, not of the person with HIV. So there seems to be clearly a connection here to family stigma. Now, finally, this is the last sort of section that I'm going to show you. We asked them to imagine a person living with HIV. We've also got data on the age and the gender and other aspects of this person that they imagine. There just isn't time to share that with you. We got them to imagine the person and then to rate the person on a widely used series of social psychological scales that examine the different dimensions of person perception. And so what we found is that in Hong Kong, these are small but reliable differences. There's a tendency to see the person as being less moral than in Australia. There's no difference in how sociable the person is. And there is a difference in terms of the competence. So the morality and the competence are the two key dimensions of person perception generally. So the person is seen as being less competent, but there's no difference. We were also interested to see whether often we see in social media and other sorts of areas this idea that people who are living with a challenging illness somehow develop a sort of magical toughness and strength and endurance, and we sort of call that grit. But in fact, people don't perceive people living with HIV as having any more or less grit, whether they're in Australia or in Hong Kong. But there are differences in terms of the morality and the competence. So first of all, I guess I just want to emphasise that these are differences between Hong Kong and Australia that, in terms of HIV, that I thought were particularly relevant to what we're talking about this afternoon. There are, as I said before, there are plenty of things where Australia stigmatises much more than other countries, such as, for example, obesity. But we've seen the sort of the distinction, I guess, between the Hong Kong and Australian data in these particular aspects. And what I think is of interest here is not so much we know that the stigma is there, and the stigma is there in different places, in different ways. It's about why is the stigma happening? What is actually driving the stigma, and what are the facets and particular functions of stigma here? What I think, I'll get back to the first point in just a second. What I think we can see here is that the nature of public stigma in Hong Kong really seems to be much more strongly avoidant than approaching. That is, the emotions are those of avoidance, disgust and frustration and contempt. They're not the emotions of approach, such as anger and pity. So the real issue in some ways appears to be that there's a belief that in Hong Kong we're sort of trying to keep people away like that. And in that sense, I think we understand that there are beliefs, there are negative beliefs that involve the family and other aspects of the person's life. And so I think in terms of future research, first of all, we want to understand that really much more now the interconnections and the essentially the networks of these different factors as they occur in Hong Kong. Secondly, one of the things I think we need to do now in pressing ahead with a kind of a jointly quantitative and qualitative approach is to make use of the language people are using, the language as a way to quantitatively assess, and we're doing this now. I'm kind of like surrounded by linguists where I work, making use of people's language as a way to quantitatively assess both the level and the nature of the stigma that they express. I'll only say a couple of things in terms of implications for healthcare. We've heard lots of them. I found myself nodding furiously as people were talking throughout the afternoon. I think a key thing is I'd sort of focus on the second point in terms of focusing on encouraging adaptive beliefs around the place of people living with HIV in the shared social space. I think that's the way of really directly contrasting against the avoidant and rejecting as aspects of stigma that we understand are probably still out there. So I'll be glad to answer any questions during the Q&A, and if anyone has any further interest, do feel free to get in contact in the usual ways. Thank you.